Hi, I'm Justin McKinley, and this is my case study on a patient with schizophreniform. This patient is RP. He was a 27-year-old Caucasian male seen at the inpatient unit. A lot of the information throughout the case study and that we had to get from him was ultimately obtained partly through him and partly from his family. Uh, he was very paranoid and would not do a lot of conversing with us. He was single, he was never married, and he has no children. He resides in his truck on quote unquote where the road takes me, and he was unemployed since the beginning of COVID. And he formerly was a fast food worker who he lost his job around the time COVID had started, and he tried to find another job. Kind of refused to live with family. Ultimately, he became homeless, living out of his truck, and this ultimately was basically the start of a lot of his symptoms. His chief complaint was I wouldn't be here if people would just stop those guys from trying to murder me. He was, again, a 27-year-old male seen in the inpatient psych unit, which is basically a lot of schizophrenia style patients. He was brought in last night after police were called for trespassing. He was found wandering in the parking lot of the local college, yelling at what appeared to be himself. RP states that there were a group of mafia following him with rifles trying to kill him. He would ask those in the parking lot, but they denied seeing anyone. So ultimately, he was taken to the ER for evaluation. He's currently denying any anxiety or depression, or SI or HI. The big thing with him, the reason I kind of chose him was he kind of stood out because initially we had kind of assumed, like many of the patients that we see in this unit, we assumed there would be drugs on board, and it would be a drug-induced psychosis, which typically we weren't treating for the first couple of days to give the drug some time to clear the system and see if it was drug-induced or if it was true psychosis. He was one that, after speaking with his family and getting his labs back from the ER, and then us doing a drug urine screen, everything coming back negative, we were pretty sure that he, would actually be a true psychosis, especially in the age range that he was in, rather than just something that was induced by the drugs. His past psychiatric history was he was denied any diagnosed psychiatric illnesses. We had asking about his family. All he would say is his whole family was crazy, but they think he's the crazy one. But in talking with family, there was no history. Medical history is his self. He denies anything medical. His general health is good. Um, and he again states he doesn't have a relationship with anyone in his family, so he has no idea of their medical history. But speaking with them, they were all pretty healthy. Social history, he denies friends or any of supportive figures in his life. He did initially, speaking with family, he had that support in the beginning, which he chose to not take the handouts when he lost his job, and ultimately again led to his homelessness. His mental status exam is he was alert to person, place, time, and situation. His remote memory was impaired, but his recent was intact, which was evidenced during the assessment. His cognition was very black and white. It was very concrete. Concentration, he was attentive, his attention and concentration were both very poor. He We needed to continuously readdress him, try to bring him back to the conversation. He would not stick with the conversation for very long before being losing his concentration. His He was cooperative when we could get his attention and get him to kind of get back to the conversation, but you could tell that he was just not engaged in what we had to speak about. He was more worried about the mafia finding him, seeing things going on outside of the window. Was just very paranoid. His poor he had very poor eye contact as well during the assessment. His mood was he was very irritable. He was also very anxious and paranoid. His affect was very inappropriate and restricted. Psychomotor, uh, he continuously paced the room from the window to the door. Again, just trying to be. He was worried that the mafia was coming after him and that everyone there worked for him. Fine and gross motor skills were normal and under the patient's control. His gait was also normal. Speech was English, but with a rapid rate, but he did have a normal tone and volume. His thought process was very paranoid, but he was devoid of any suicidal and homicidal ideations. His insight and judgment were both historically and currently poor. The NANDA diagnosis I gave is ineffective health management related to his homelessness, interrupted family processes related to his loss of relationship with the majority of his family, and risk for acute confusion related to the new onset of psychosis. The DSM-5, as he fit the schizophreniform disorder with good prognostic features, and the reasoning the schizophreniform was because of the time frame. It had been going on now approximately 4.5, almost 5 months. He also so it wasn't, he definitely wasn't quite the schizophrenia, but he was getting there, and he the good prognostic features was he didn't have any that negative affect yet, and it was pretty new onset, kind of a quick onset with something that may have caused him to get to that level. Case formulation. The problem in this case is that for a known reason, the patient started having some psychosis. His increased life stressors, such as losing his job that led to his homelessness, could have caused this psychosis. Having family that potentially may not have helped him in this crisis could have contributed to this issue. The homelessness is a factor that is causing him stress that he has not yet decided to try and improve. He was convinced he wanted to continue basically to live out of his truck and that he was happy the way things were. So he may continue to contribute. So this all may contribute to continuing psychosis if it's untreated. And therefore, the plan was antipsychotics so he can be started to help rid him of the psychosis, thus allowing him to start living a normal life again. The treatment with rationale. First, we wanted to make sure to rule out the psychosis from any other cause. So we did do the drug test, all of his labs, STD check, including the syphilis. All of these results did come back normal, however, which we were all kind of shocked with because, again, this is something he was in the age range for new onset, and he appeared to be that patient. So we started him on risperidone, 1 milligram, 1 tablet POBID for the psychosis. The reason we started Risperdal is it's easy to go up on the dose, and if need be, down the road, we can change over to injections. Here is the Risperdal treatment, or Risperdal, how it works and all that. His class is an atypical antipsychotic. Indications is FDA approved for schizophrenia for 13 and older and acute mania 10 and over. Autism-related irritability 5 to 16 years of age, and bipolar maintenance. Off-label use for bipolar disorder, behavioral disturbances, and dementia, children and adolescents, and disorders associated with impulse control. It does block the D2 receptors, reducing positive symptoms and stabilizing affective symptoms. Blocks the 5-serotonin 2A receptors, causing an enhancement of dopamine release in certain brain regions, and thus reducing motor side effects and possibly improving cognitive and affective symptoms. Also, serotonin 7 antagonist properties may contribute to the antidepressant actions. Oral dose, starting at 1 milligram a day in 2 divided doses. Increase each 1 milligram day till desired effect. Usually max is 16 milligrams per day. Education. Because of the metabolic syndrome, we ensure that the patient is aware of all of the testing that is necessary and symptoms of some of these symptoms of some of these conditions. It does have dose-dependent EPS, so typically above 6 milligrams. We ensure the patient reports these if they occur. May cause hyperprolactinemia, so also to report this. for the patient. May cause sedation and waking, and the medication oral solution is not compatible with cola or tea. It's metabolized by 2D6, and it may increase the effects of hypertensive agents. Co-administered with fluoxetine or paroxetine may increase the plasma levels of risperidone. It also may antagonize any levodopa, dopamine, or any other dopamine agonist, and it may enhance QTc prolongation if the other drugs that do the same as well. For him, the non-pharmacological treatment, we wanted him to make sure to find hobbies that were enjoyable for him to focus on while he was on the inpatient side, and to be physically active with his mind body exercises like yoga or tai chi, and partake in the different yard time that they would receive throughout the day. And most patients with schizophrenia are treated by community mental health teams, CMHTs, or SMI clinics teams. The benefit of these teams is that they will cover many of the needs of the patient that are deemed to be SMI. They are evaluated, and once they are deemed to be SMI, then they can receive potentially a significant amount of resources, which include the medications, the medical treatment. It can take care of housing and food, but all of the stuff that it can provide will help to alleviate the stressors of the patient's life, and thus they are more likely to continue treatment.